Okay, thank you very much. Can you all see the slide on the screen?
Yes. Yes.
Okay.
Yes.
Okay, you can now? Okay.
No.
Yes, we can.
I'm not sure why some of you may not be able to. Maybe if you try the GoToMeeting controls, you'll be able to come up with something that will show my screen, but you should have the title slide, ACA Reforms, Mental Health and Single Payer. This is a presentation that I put together geared toward medical audiences, particularly those who are trying to struggle with the payment and delivery system reforms envisioned by the Affordable Care Act. And my review of the evidence on what will or won't work about those and what would be better. Okay, the big problems with U.S. healthcare are cost and access. And the idea that has been used by health policymakers is that we must reduce costs and therefore we need to restrict access to care in order to save money. Right? But restricting care and access does not restrict disease, which pops up in uncontrolled and more expensive forms elsewhere, complications, ER, and hospice. And then sicker patients are pushed out of for-profit health insurance plans and onto the U.S. default high-risk pools, Medicare and Medicaid. The other problem with this idea is that when you start trying to restrict care or access or eligibility, these all require bureaucracies that end up costing more than they save. The Affordable Care Act attributes excess cost to too much care and blames fee-for-service causing excessive volume of services. And therefore, we need, according to this theory, we need to have financial incentives for doctors and hospitals to deliver less unnecessary care and to increase cost shifting to patients so they will become more judicious purchasers of health care. All right, U.S. healthcare costs. As you all know, we spend far more on healthcare than any other country, and even our public spending is greater than that, than the total healthcare spending of any other country. What about access? We have much worse access than any of these other countries. Our outcomes are significantly worse in life expectancy, preventable mortality, infant mortality, maternal mortality, all the major public health indicators. Well, are we using too much care? We have among the lowest hospital inpatient days per capita of any of these countries. We have the lowest physician visits per capita of any of these countries, so it doesn't look like we're actually overutilizing healthcare. Can higher patient cost sharing control healthcare costs? We already have the most skin in the game. Our out-of-pockets are higher than any of the other industrialized countries. This is a study that implemented co-payments for some patients but not others, and in the co-payment group, it did indeed reduce outpatient visits by almost 20%, but hospital admissions and hospital days went up substantially, and of course the hospital day is about 100 times more expensive than an outpatient visit, so this did not save any money. So the reality is that restricting access actually increases cost. And even though this may be counterintuitive, that's what the evidence says. We already rely heavily on incentives to deliver less care and pushing more costs onto patients. These costs we should not be spending twice as much as other advanced countries. Okay, cost control strategies. Let's look at HMOs, managed care, and accountable care organizations. Traditionally, HMOs define them as overutilization, and the idea was to shift insurance risk to competing capitated managed care organizations, which would then try to restrict unnecessary care by restricting network, restricting formularies, and implementing prior authorization. This is Hawaii's experience with Medicaid managed care. We converted fee-for-service Medicaid managed care organizations in 1994 and 2009. 94 was for the general assistance and aid for dependent children population. 2009 was for the aged, blind, disabled, who are the ones qualified for disability by Social Security. This led to greatly increased administrative hassles and costs due to prior authorization policies and restricted formularies, and there was some decline in physician participation. But the initial phase in 94 was done with local nonprofit plans, and they backed off on the prior authorization requirements, and things got somewhat better. Then when we implemented...
Stephen, can I just interrupt you a second? There's some really bad feedback on the call.
People need to mute their mics. Everybody but the speaker. That will help.
Can everyone hear me? That sounds quieter now. All right, so when we implemented managed care for the aged, blind, disabled in 2009, it was done with two mainland for-profit companies, United Healthcare and WellCare. And these were separate from the plans for the general assistance and aid for dependent children populations. And they imposed much more restrictive managed care policies with restricted formularies, prior authorizations, and all that, even worse than what we experienced at the beginning with the local plans. And the result has been rapidly worsening access problems. Physicians have been dropping out of Medicaid. Our total cost for the Medicaid budget was rising but on track with the national average as of the mid-90s, and since then it's been going up 2.7% faster than the US average, so obviously this has not saved money. We have data on mental illness from 2009 to 2013. Since managed care was implemented for the aged, blind, disabled population, more than half the formerly participating psychiatrists have dropped out and are no longer taking new patients. And mental health, ER, and hospital costs increased 30% during this 4 years. The Affordable Care Act likewise relies on financial incentives for less care. The idea is to align hospitals and doctors into shared financial incentives for cost-effective care, and then shift insurance risk to the accountable care organization and then to providers. This is being done in the form of bundled payments, shared savings, and capitation. And patients are attributed ACO based on their utilization patterns, and this is primarily where they choose their primary care doctor, and they don't choose or know they are in an ACO. This is like HMO, but with the patients not knowing where they are and being free to go to any doctor they want. Okay, shifting insurance risk to providers. This means you get paid for the care of a population, and if care is expensive, you lose money, and if you deliver less care or less expensive care, you make money. This incentivizes providers to restrict care, to cherry pick and avoid sicker, more complex patients, to game diagnosis to beat risk adjustment formulas, and to game documentation to improve reimbursement. It also leads them to become more focused on money at the expense of their patients' welfare. Pay for performance. Okay, physician motivation. There are two broad categories of what motivates physicians. The first is the intrinsic motivation, or the desire to do the right thing for the patient based on traditional professional ethics. And the other is extrinsic or financial motivation. Consequences of pay for performance, which relies on extrinsic motivation, are the measures for performance are grossly inadequate. It promotes physician greed by relying on extrinsic motivation. It leads to gaming of documentation for payment and corruption of healthcare data, and it leads to fraud and abuse. These are all unintended consequences by the designers of pay for performance. I'll say that the measures, anyone who thinks they can measure quality in healthcare has not come to grips with the complexity of healthcare and the difficulty of doing that. I spent 15 years on the board of directors of Mountain Quality Health Foundation doing quality improvement projects for Medicare, and we never could come up with measures that got at more than a small sliver of healthcare. The assumptions implicit in pay for performance. First, performance can be accurately ascertained. Second, individual variation is caused by variation in motivation, and doctors need more motivation to provide cost-effective care. That financial incentives will add to intrinsic motivation. That the current payments system is too simple. And that hospitals and doctors deliver poor quality care should get fewer resources. All of these are highly questionable assumptions. Can we measure quality in healthcare? There are an estimated 25% of patients in a typical primary care practice that are complex because they have atypical presentations, unclear diagnoses, multiple interacting conditions, complicating psychosocial factors, etc. Quality in healthcare is very difficult to measure due to its complexity, and the available measures are either grossly invalid or narrowly focused on what is easy to measure. These are studies on the quality scores of Harvard physicians based on whether they had poorer and minority patients or were treating primarily middle class, wealthier patients. And you can see that the quality scores depended heavily on what their patient population was like. The red are the bottom scoring patients, and they were disproportionately seeing minority, non-English speaking, and uninsured Medicaid patients. Medicare's premier demonstration, 252 hospitals looking at pay for performance. The 5-year outcomes mortality showed no effects or negative effects, and particularly if you look at all conditions, there was the net negative effect of pay for performance on mortality. Cochrane review looked at, this is a meta-analysis of pay for performance studies done a couple of years ago, and they found no evidence that financial incentives can improve patient outcomes. Pay for performance is official Medicare policy widely adopted by private payers. There are no controlled studies showing that it works, no improvement in the largest demonstration projects, and concern about unintended adverse consequences. ACOs are the newest health policy panacea. Again, no evidence to back them up. And implementing everywhere interventions which have been proven nowhere risk failure on a colossal scale. This is Don Berwick, former director of CMS, now running for governor of Massachusetts, who says, I do not think it's true that the way to get better doctoring and better nursing is to put money on the table in front of doctors and nurses. I think that's a fundamental misunderstanding of human motivation. People respond to joy and work and love and achievement and learning and appreciation and gratitude and a sense of a job well done. It feels good to be a doctor and better to be a better doctor. When we begin to attach dollar amounts to throughputs into individual pay, we're playing with fire. The first and most important effect of that may be to begin to dissociate, particularly physicians, from their work, so they are no longer thinking of their work as a profession, but as a business. Managed care and quality improvement. I distinguish between central and peripheral management of care. Managed care is central management by policies controlled by an insurance plan or managed care organization. And continuous quality improvement is peripheral management controlled by care providers at the local level. There is some appropriate role for central management, such as dealing with outliers who have very aberrant practice patterns, or for drugs, diagnostic studies, and devices that are shown to be abused or misused, where you might want to implement some kind of intervention or prior authorization policy. However, prior authorization lists should be pruned regularly, and if it appears that, say, a drug is prone to misuse, but you find that after a year you're approving 98% of the prior authorizations, then you would drop it from the list and only continue to manage those things where there's a shown need to have them managed and where there's some benefit to doing so. This would leave most providers practicing appropriately alone. And there should also be practicing physicians who control managed care policies to keep them accountable to the realities of patient care. Some examples of what I mean by peripheral management. Intermountain Healthcare in Utah has developed this model the farthest. What they do is have physician nurse trainers who go to different hospital units and clinics and work with the doctors and other staff looking for areas where there's a lot of variation in processes of care. And the example that they use is ventilator settings for patients with adult respiratory distress syndrome. And in a hospital in Utah, there's a lot of variation in the settings. Each doctor came up with their own protocol. And they had the doctors and other staff in that critical care unit get together and work out a protocol for what the best practice would be for ventilator settings, but with no punishment or adverse consequences for deviating from that if there was a reason to do so. And the process of putting the protocol together resulted in doctors moving closer to that protocol, and there was then less variation in ventilator settings. And this resulted in improved outcomes and reduced costs, both. This has to be done at the local level because it requires feedback from the doctors after a protocol has been implemented to modify it if it's not working right or doesn't seem to accurately reflect what needs to be addressed. So there's a fine-tuning feedback process to improve the protocols. You can't do that with central management by a health plan. It has to be done locally. And in Utah, they estimate that if this sort of thing were implemented widely, it could save perhaps 5 to 10% of healthcare costs. In Mesa County, Colorado, Rocky Mountain Health Plans they've been doing this over 20 years. It was led by primary care physicians in the community. They offer commercial employment-based health insurance. They obtained a contract to deliver all of Medicaid services for Mesa County, Colorado, and they developed a Medicare Advantage plan to capture the Medicare population. They then merged the funding from all of these sources and paid doctors the same blended rate for every patient, no matter what the source of their funding was. They also have a physician-led quality improvement program similar to the one in Utah that I just described. And their results have been, there are no access problems for their Medicaid patients. They're treated the same as any other patient. And they have enough primary care doctors so that they are able to find a doctor when they need one. And if you compare Mesa County with the rest of Colorado, they have minimal expense for federally qualified health centers because there is no need for them. The patients can all get care in the private sector without difficulty. For physician care and EPSDT, which is screening for pediatrics, they're spending half the rest of Colorado. For pharmacy, less than half the rest of Colorado. For inpatient hospital, half the rest of Colorado. And for outpatient hospital, half the rest of Colorado. I trained in psychiatry at Cambridge Hospital, and there again, the Department of Psychiatry contracted to provide all the Medicaid mental health services for Cambridge and Somerville with no competing managed care plans. We provided comprehensive services and programs, including a state hospital unit, a general hospital psychiatric inpatient unit, outpatient services, specialized services for the seriously mentally ill, and community consultations. Because we had catchment area responsibilities, we felt obligated to reach out to meet the needs of all the patients in the community. And if someone had a problem that wasn't fitting with what we were doing, we would try to be creative in coming up with ways to address that patient's needs. We use interdisciplinary team care with good care coordination. There was high morale, low administrative costs, and good quality of care. And again, there was no central management of care by insurance plans or government. With central managed care, the goal is to reduce utilization and increase, quote, quality, unquote, scores. The measures are set by the health plan. The incentive for the plan is to restrict care. The incentives for providers is financial. And there's an adversarial relationship between the plan and providers. And this means high administrative costs. With peripheral continuous quality improvement, the goal is to reduce variation in the processes of care. The measures are developed by providers. The incentive is to improve patient care. It's incentive neutral as far as physician pay goes. And there's a cooperative relationship between the plan and providers because they're the same. And this involves very low administrative costs. There's really the only cost is the trainers. Otherwise, there is no central administrative cost to it. So let's look at managed care, HMOs, and ACOs. How have they been working so far? This is the growth of physicians versus administrators. The managed care era began in the late 80s, early 90s, and you can see what's happened to administrators. Hospital billing and administration, far higher in the US than in Canada, where they have a single payer system. Same with physicians billing and office expenses. And overall administrative costs, far higher in the US. CMS reported recently on pilot ACOs so far. Only 29 of 114 ACOs saved enough for shared savings, and they had 23 pioneer ACOs which took more risk, supposedly a more advanced model. And they did lower Medicare spending by 0.5%, but the savings were offset by administrative costs. And when you include the administrative costs, these pioneer programs resulted in a net cost increase of 0.5 to 1.5%. There are very few primary care practices that have enough patients for statistically valid quality and cost metrics. There is a recent multi-payer certified medical homes study where they had to meet the certification criteria to be a patient-centered medical home, and these failed to improve quality, utilization, or cost. I think they did better on 1 of 11 quality measures and no better at all on utilization or cost. Their study recently, these are all from the last few months. 2/3 of ACO patients got their specialty care outside of the ACO, especially the sicker, high-cost patients, which means that if you've got an ACO that's being held financially accountable for the cost of the patients in their care, that 2/3 of those patients are going to be getting care outside of the control of the ACO, so they're being held accountable for something they can't control. Most ACO payments, if you base payments on quality metrics and give incentives for meeting quality metrics, it turns out that most of the doctors in an ACO are already providing cost-effective care. So they get the bonuses for doing nothing different, and they're called free riders. And even if you manage to rein in excessive care by the outlier providers, the cost of the bonuses to those free riders outweighs any savings you get from reining in the outliers. So the whole program ends up costing more money than it saves. Managed care burdens have been worse for psychiatry in the 1990s. At least here in Hawaii, we were subjected to 100% prior authorization. You could see a patient once, and then for inpatient visits, you have to get approval. You have so many visits. This has resulted in a drastic decline in psychiatrists participating in Medicaid, and a drastic decline in access to care for the seriously mentally ill, and a rapid rise in mental health ER and hospital costs since conversion to managed care. Right now in the whole country, psychiatrist Medicaid acceptance rates are the lowest of any specialty. The Affordable Care Act, can it work? We all know about the website rollout complications, which remain a problem in many areas. I think they're improving the US plan, but Hawaii is still a mess, and so is Oregon. The ACA is pushing people into low-value plans that deter needed care. For example, an individual making $25,000 a year would be eligible for maximum subsidies. And even if their premiums are affordable, if they have any significant illnesses, they can be on the hook for $7,500 a year in premiums, deductibles, and copays. And that's a quarter of their income. I can't imagine anyone making $25,000 a year who could possibly afford that. And the consequence is going to be a lot of unpaid bills for doctors and hospitals. There are also serious access problems that are not addressed by the Affordable Care Act. We're expanding insurance, but there's a shortage of physicians. Many plans have narrow and ghost networks. Ghost networks means they claim these lists of doctors participate, but if you call that doctor, they won't actually take the plan. And our Medicaid system is very dysfunctional, particularly when it's been converted to Medicaid managed care, or when the fees are so low that no doctor will take it. So the ACA preserves the private competitive insurance model. It leaves obstacles to access in place. Cost control is aimed at further restricting care, pushes more cost on the patients. It shifts insurance risk to doctors and hospitals and increases administrative complexity and cost. All of these are counter to the evidence for what would actually achieve triple aim goals of better quality, better health, and lower cost. Can the Affordable Care Act work? It doesn't work for sick people, and it relies on strategies that have been shown to increase costs. Let's look at the single payer alternative. This means single payer means public funding that pays for the health care of the entire population for a geographic political entity, and can involve either private care delivery, such as through Medicare, fee-for-service Medicaid, and the Canadian system, where doctors are self-employed small practices and hospitals are privately owned. Or it can involve public care delivery, such as the VA, military health, Indian Health Services in Great Britain, where the government owns the hospitals and employs the doctors. Both eliminate private health insurance except for supplemental benefits not covered in the single payer program. HR 676, everyone covered for all medically necessary care, minimal or no deductibles and copays, access to care based on need, not means. Insurance risk is managed by risk pooling alone, pooled across the entire population and not shifted onto doctors, hospitals, and patients. Vastly simplified administration and minimizes centralized management of care and bureaucracy. How does cost control work under single payer? It's basically a three-step plan. The first is to assure access to cost-effective care or care in the most cost-effective settings for everyone. Second, simplify and streamline administration. And third, use administrative savings to reduce prices. If a hospital is put on a global budget, billing and collections are now about 20% of a hospital budget. They have a global budget and are paid upfront to deliver care for the population. They can eliminate their billing department, and hospital fees could be reduced 20% without hurting the hospital's ability to provide care. For doctors, the Canadian system and HR 676 both allow collective bargaining by physicians, so they can band together and negotiate fees with the government rather than having government unilaterally set fees the way they do in some other countries. There'd be vastly simplified administration. In many countries, the patient has their healthcare card, which they can swipe through a card reader at the end of the visit. The doctor punches in the procedure code, and they get paid a few days later, and they don't need coders and billers and all that kind of thing. It's been estimated that a single payer saving would reduce 10 to 15% of physician practice expenses, and you could reduce their fees accordingly without hurting them. Drugs and medical equipment, if they had to negotiate prices with the government, as every other industrialized country does, we could save about 40% of the cost of drugs and medical equipment. If everyone had the same comprehensive coverage, it were administratively simple to practice any specialty in any location. Physician pay were equitable based on training and practice costs without skewed incentives for procedures, or by pay for documentation and pay for performance incentives. Then many more physicians would choose primary care and psychiatry again. Patients would have access to care based on need, and our spending would be similar to that of other developed countries. I've given some thought to how I would want to design mental health care under a single payer program. I would pay physicians either fee for time or on salary, and the idea is to make physician pay incentive neutral, or as incentive neutral as possible. Fee for time is what we used to have in psychiatry when we had a med management visit, a half-hour psychotherapy session, or a 45 to an hour-minute psychotherapy session, and you would plan or schedule a session based on what you thought the patient would need. You might go a little over or under that time in the actual visit, but your fees are based on what you scheduled, and it was based on time. They converted us to evaluation and management codes about 1.5 years ago, And since then, I've been spending an extra hour a day on documentation. I am having to pay a lot more attention to the charting than I used to, and it's made me a less efficient psychiatrist. But I will say it's resulted in about a 10% increase in my income, which I like, but it's at the expense of time with family and everything else, and a less efficient practice. I think child psychiatrists need to be paid more for their extra training, and specialized services for the seriously mentally ill should be set up as a public utility. They should be community-based, publicly funded with a global budget. Services should be available based on patient need, not on eligibility criteria or diagnosis. So if a patient is crisis prone in and out of the emergency room, it doesn't matter what their diagnosis is. You can call up the crisis program and arrange for a case manager and more intensive services to try to keep them out of the emergency room. These specialized services should be collaborative with interdisciplinary teams. There should be crisis services, case management, psychosocial rehab, day programs, short-term hospital and long-term hospital, and substance abuse services. And psychiatric training should be focused on the SMI population. I think this sort of thing would be the most cost-effective and the most effective way to make psychiatry address the needs of the community. And that's my last slide, and I would be open to any comments, feedback, discussion, further ideas that any of you may have. You'll have to unmute yourselves to speak.
Steve,
Yes.
this Nick Anton, I'm from Northern Kenya. This is kind of a technical question, but in looking at the other slides that we get from PNHP, occasionally I'll use one of their slides in one of my own presentations. When I tried to transfer one of your slides to an empty slide in one of my presentations, it wouldn't allow me to do it. And is there something unique about your slide set, or am I doing something wrong?
I'm not aware of any obstacle to doing that. I created these in PowerPoint on a Mac and didn't do anything to block anyone from accessing them. I'm not sure.
I mean, I have a Mac also, and PowerPoint in a Mac, and what I get is a red X that says either you don't have enough memory or something's wrong with the slide. I don't know. Maybe I'll try again.
Maybe I'll pass it out again. Maybe it'll work the second time.
Okay, thanks. I appreciate that.
Sure.
Hey, Steve.
Yes.
Hi, there's Ali Byers from the Big Island. I doubt
Hi.
that there's many people. Hi. I doubt there's many folks who are watching this who have a whole lot of disagreement, if any, with anything you said. So my question is really, okay, so where are we at with the next steps to move towards any of this? Can you just sort of highlight that in terms of, I mean, locally I know we have, there was legislation recently, and nationally there are folks working on this, but what's the reception of momentum towards any of this?
Well, I think the biggest need right now is for more public education. And really the point of all this is to develop an argument or a line of explanation that can be used in a variety of settings that will be persuasive and get more people to think along these lines. I'm sure all of you already do, and I assume that, but we're all trying to figure out how we can get this out, how to get broader support. So that's why I'm offering this in hopes that it would be helpful to that. So I need you all to be able to download the slides if you want to use them. I think in Hawaii, I've been doing a lot of talks, and I got pretty positive response from Hawai'i Medical Association. There was an effort by some of the conservative members to overturn our endorsement of single payer a couple of years after we originally passed it, and the HMA Council shot that down by a large majority. So it looks like HMA is on board already. I did a talk for the Rotary Club recently that was very well received on the business case for single payer. The biggest problem is that the Abercrombie administration, he's our governor, When they wanted to implement the Affordable Care Act, they had no money in the budget to do so. So they went to the health insurance plans to fund their health transformation initiative and allowed them, therefore, to dictate the terms of reform. And even though there was a lot of discussion of moving toward single payer or at least an all payer system like they have in Western Colorado, the health plans essentially vetoed any movement in that direction and required that everything be kept as fragmented as it is already. And the result is our healthcare reforms are going to be utterly ineffective. I have been talking to some other legislators about this, and we may be getting somewhere. One thing that I don't know if you're aware of, Ollie, is that there was a bill to take the governor's health transformation team and gut our state health planning program, SHPTA, and replace it with the transformation initiative. And that bill died in committee at the end of the session. So there now is no place in the budget for the transformation initiative, which I was very pleased to see. We still have a long way to go to actually get the political will to implement what we need to implement.
Steve, I would just add that in Hawaii, you have a senator that's supposedly very sympathetic to single payer, potentially, Mazie Hirono. And do you think that's true? And we're actually hoping to find some co-sponsors for single payer in the Senate for the Sanders bill, and she's one that might be approachable.
I think all four of our two senators, two congressmen or women may be sympathetic, but I never really know. I thought our governor was committed to single payer because he was a co-sponsor of HR 676, and he turned the opposite direction once he got in office. So I don't know what you'll actually get if you start to talk to them, but it's worth a try. I've been meaning to try to get around to that also, but haven't. I had some preliminary discussions with all of them a couple of years ago, but not recently. I have a feeling it's going to take some further failures of the efforts to implement the Affordable Care Act payment and delivery reforms before we'll really get their ear.
I don't know who was asking the question, but if you were asking just about Hawaii or if you were asking about nationally, I think we would also say, as Steve and I both, that Vermont is, passed a bill in 2011 to be on a pathway to single payer and is hoping to implement it in 2017. A lot depends on whether or not their governor gets reelected and whether the movement can out engage versus the opposition, but that's a very promising development. We do have bills in both the House and Senate. The Michigan Medical Society recently approved $50,000 to study single payer. That's another branch of the AMA, so we were very encouraged by that. And then there will be two resolutions. There will be a resolution for single payer put to the AMA, the House of Delegates, calling for a poll of doctors on single payer, and then there'll be one put before the AMA medical student section that will be calling for the AMA to endorse single payer. And I don't by a long shot think either of these will succeed, but I do think they'll start dialogue, and that, especially now that the ACA is being implemented, there will be more and more dialogue about, this isn't working and we need something else.
Any other comments or questions?
Steve?
Yes.
Steve, this is Jim Mitchner from Michigan. Thank you for that shout out. The State Medical Society of Michigan is going to spend the next year studying the feasibility of recommending support for single payer as the preferred mechanism for financing healthcare. And so I'd like to talk with you offline sometime about, what I have to look forward to in terms of the resistance I'm going to get from some of the more conservative members. And I don't necessarily think we need to spend $50,000 to study what's been studied at least 23 times in the past from various states and nationally. But there seems to be a certain legitimacy if you hire an outside consultant and they go out and they do the studies and they find out that it's economically feasible. Apparently, that covers more weight than just using somebody else's data from another state. So I'd like to take the opportunity in the future to talk with you offline about strategizing here.
Sure.
Steve, hi.
One thing I found useful for answering questions is I have a group of slides from the PNHP slide set on Canada. And when you show them the wait times and the physician pay and the malpractice costs of the US versus Canada, it usually silences a lot of the question because there's a lot of misinformation spread about those things. And if you look at the actual evidence, the Canadian system works pretty well.
Right, and that's a good point. And the idea, my strategy has been to sort of head them off at the pass before they get a chance to get up the microphone and talk about all the bad things in Canada, is to show those slides, and I'm grateful to the PNHP people for that. The other thing is that their objections to single payer is almost always anecdotal. They know, their neighbors, cousins, girlfriends, ex-wife, whatever, who lives in Windsor, waited 9 months to get the MRI and they found a brain tumor and now she's dead, That's usually what you get. On the other hand, I've been gratified to find there are actually some people that have been to meetings who get up at the microphone and say, I lived in Canada, I practiced in Canada, I think it's a great system. So you do get the other anecdotes too.
Steve, related to that,
yeah, that's often helpful.
I see this Ali again. As you know, went to med school in Canada. I didn't ever practice there, but have friends who certainly have. And has there been much thought or action in getting any legislators from Canada? Because as you know, like in the healthcare movie, there's first on any side of the political arrangement in Canada, there's nobody who, after however many years, 30 plus years that the system's been going there, there's no legislators who even begin to talk about revoking or changing the system completely. And is there any thought of getting legislator to legislator contact, Canadian legislators to talk to American legislators and convince them, or at least discuss with them, that this has not been a disaster in Canada and things work fairly well?
Ida, has PNHP done anything with that, of trying to link up US legislators with Canadian legislatures?
Not that I know of. I think that there have been some legislators who have been on speaking tours of the U.S. That would have been like in the early 90s, before the Clinton health plan. That was kind of a popular thing to do, go on study tours of Canada and bring Canadian speakers here. But that's definitely something worth considering. There are also some really good labor leaders in Canada who have come and spoken, done speaking tours across the U.S. and have been really done a really good job in explaining their system and being very, compelling about how good it is both for workers and for business. So,
and then there's always Dr. Martin.
About that.
There's always Dr. Danielle Martin.
Very remarkable.
Hi, this is Nick Antone again from Northern California. My wife and I just recently completed a train trip to Canada and fortuitously met a couple in Quebec City. David Butler Jones, I don't know if any of you know him, but he was basically acting as their equivalent of the Surgeon General of Canada during the SARS epidemic 3 or 4 years ago, and kind of was in charge of the entire Canadian healthcare system, dealing with epidemiology and what the CDC does in the United States. And I think he's retired now because he had a mild stroke, but he goes around and continues to give talks and has worked with Bernie Sanders in the past. I think would be a good type of. He testified before Congress at one time in the United States, and I think he would be the kind of person that might be available to come to the United States and give some talks or presentations.
What's his name? David Jones?
David Butler Jones. It's a hyphenated last name.
Uh-huh.
So you think he's a good speaker despite his stroke? He can get around and
oh yeah,
he
basically retired because he said his stroke was basically some cognitive problems. He seemed perfectly normal sitting and talking to him, but he said it was too much stress doing this job, so he retired 2 years ago. But he actually gives talks on, signs of stroke and et cetera. And I think he would be somebody we could maybe approach at least.
Another question that I've always gotten from mixed audiences is about, well, wouldn't single payer mean a huge government bureaucracy? And that's why I like this slide, my slide on single payer cost control, which emphasizes that what we're talking about is simplifying and streamlining administration. And if you were going to leave all of the attempts to centrally manage care in place, it would not be what we're talking about at all. But people assume that that's what it would mean. And that's a very important thing to get across when people come up with that objection. What's the point if you're not going to simplify the administration? That's where all the savings are.
How do you deal with the argument when docs say that the disadvantage of single payer is that you have no ability to negotiate like you do now when you have multiple payers?
I don't think that we actually have any ability to negotiate with multiple players, at least we don't here in Hawaii, other than you can say, I won't participate in your network. And with single payer, there are some countries where the government unilaterally sets fees, and they tend to underfund physicians. This is true in like some of the Asian countries, Taiwan and Japan. And some of them allow some kind of escape valve. Like in Japan, they let doctors sell drugs out of their office to make up what they're not getting paid in the fees that are set by the government. But the Canadian system does allow collective bargaining by physicians, and so does HR 676. And so that's what I always say is, we would allow doctors to negotiate fees, and they would not be unilaterally set by the government.
Steve, Ali Barros again. I just wanted to comment on some questions I see here in the chat box from Elizabeth Rosenthal. And I don't have any direct understanding of how the government got stuck in these wrong assumptions, except that I've worked with CMS quite a bit in the last several years on some major grants that are on the Big Island. And my experience in those is that a lot of the Washington people who are at the top of this hierarchy are incredibly young people, extremely bright, out of Harvard or Yale or wherever, who study these things, and on paper they must look like they make sense. But a lot of these people are say, really very young people who have no experience in the real world. They certainly are not physicians or nurses, and not really in healthcare in any way except in healthcare policy as defined by themselves. So that's my only take on it. These are people who are really dealing in almost an alternate reality that doesn't relate to what we do every day.
I've been struck by exactly the same thing in Hawaii's administration under Abercrombie. He has these young people who are excited about this idea of setting up patient-centered medical homes and community care teams, but the way that they're implementing it is completely out of touch with the reality of patient care. It ignores things that are working and disrupts them with things that are unproven. And it's exactly what you're describing. It's been kind of shocking to me how disconnected it is from the reality of actually trying to take care of people with health problems.
So neither of us answered the last part of Elizabeth's question, which was how can we fix that? Because I don't know.
I don't know either. I've been trying to think about that. How do you get past people's blinders? How do you get them to drop their assumptions? and look at things fresh. It's not an easy thing to do.
One way, and it would be costly, and this is a thing I have, with our local public hospitals too, and trying to transform them, is that if you could take some of these people and, for example, take them on a tour of a place like Canada where it actually works and let them see the reality of something that they intellectually think is impossible, and yet let them see that really on a day-to-day basis it does take care of all the population at no great harm financially to anybody. That it's really like the Coast Guard, the Air Force, everything that we all need, and we just figured out a way to pay for it that doesn't hurt anybody individually very much.
Yeah, that's a good idea. I got started in this by looking at what works also, and I guess you got to get other people to where they're actually seeing the things work. But yeah, I'm not sure how to logistically arrange that, but it would be a good way to go.
This is Steve Tarzinski. I think another thing is a lot of these young people that are the government wonks, as Elizabeth said, they're young and they're coming out of universities, management schools, and public health schools, and they have little exposure to people who advocate single payer. So I think if we want to reach that particular cohort of people, we'd have to have more of a presence in the management schools and public health schools, at least try to do that, and get these people while they're still in formation before they go to work.
While their minds are still open.
Steve, hi. This is Dan Johanna. I'm new to this and to start lecturing. I'm at the University of Chicago, and I have been talking about this, but now I'd like to go out and actually see if we can change some minds. It seems to me that these slides are really terrific. I think some need a little more reference, particularly like the why is pay for performance, what's the evidence for fraud, and things, a few other places. But it seems to me that the most persuasive slides outside of healthcare professionals like us who know how the system is broken, who are doing it every day, is the business argument. And businesses may drive this, large business corporations. They may even be able to get past the corruption of our politicians because they're bought. And I think these young people that I've met actually know about single payer systems, but they're really not able to let, they're not really able to do anything because the amount of money that's put in by insurance and pharmaceuticals and doctors who don't want this. So I think it's going to be a business argument. That's what will sway a lot of people. And I'd like to see, I haven't looked at all the slides that are available, but I'm going to pull out as many business arguments as I can.
I have another shorter slide PowerPoint that I put together at the same time as this one. That's the business case for single payer that I gave to the Rotary here. And it's a 20-minute presentation, but it's very focused on business. And I'll send that one along with another attempt to send this one around to PNHP to distribute to the people on this list, Matt and
this is particularly the last couple slides on the most recent slides on the failures of pay for performance and ACOs. They're pretty compelling for the healthcare group, for those in healthcare, but I'd like to get as many.
They're not relevant to business.
Right. Really terrific slides. Thank
you.
Steve
Tarzinski, we'd be very interested in seeing the business ones here in California. So thank you for sending them.
Sure, I'll send both of those out.
Yeah.
I would just mention that in Vermont, the small businesses support for single payer has been a big driver of support for the system. The governor is a small business person, and he says, you know, it doesn't matter if you call it healthcare premiums or a tax, it's the same thing. And single payer in Vermont might be the biggest tax increase in Vermont history, but as a business person, he knows it's also going to be the biggest health premium reduction in Vermont history. So, and of course, that state is almost all small business. The only really large business they have is IBM, which has been very unhelpful, and you know, it self-insures, and they think they can control costs better than anybody else. So, so they've put up resistance, but small business has been very supportive. And there are these new associations of progressive small businesses in many states and nationally that are really worth reaching out to. I think in Vermont it's called something just like Vermont Businesses for Social Responsibility. And it's not just Ben and Jerry's anymore, it's a lot of organizations. And I think these more progressive business groups are kind of taking on the Chamber of Commerce in different states. You know, they're setting up alternative business groups. So they might be worth seeing if there's one in your state.
Thank you.
Okay, I think we're getting to the top of the hour. So I want to thank you all for participating. And I will get those slide sets out to you all.
Thank you very much,
Steve,
for doing this.
Thank you.
Great.
Thank you very much.
You're welcome.
Okay.
Thank you.
Good night.
Bye.
Thank you very much.